This UCSD TV program is a presentation of University of California Television for educational and non-commercial use only.
We all strive to live a long, prosperous, and healthy life. With advances in health and medical sciences, this goal is ever more attainable. The Sam and Rose Stein Institute for Research on Aging is a non-profit organized research unit under the auspices of the University of California at San Diego, committed to advancing lifelong health and independence through research, education, and patient care. To better empower and improve the lives of young and old alike, the Stein Institute presents the following program.
Good evening, everyone. I'm Maureen Curran. I'm the Executive Director of the Stein Institute for Research on Aging. I'd like to welcome all of you tonight and thank you for braving the inclement weather outside. So now it's without further ado that I get the pleasure of introducing our speaker tonight, a great colleague, esteemed colleague here at UCSD, Dr. Jim Brewer. Dr. Brewer received his MD, PhD from Stanford University. He completed his residency in neurology at Johns Hopkins, after which he came here to UCSD and joined the faculty. He does world-renowned work related to imaging and memory, and he has several highly regarded publications in the biomedical literature. He holds several federal research grants and really focuses again on memory, Alzheimer's disease, neuroimaging. So without further ado, I welcome you to present your talk tonight on new images of memory and aging in the brain. All right, so now.
All right, well, thank you, and I really appreciate the invitation, and I appreciate you guys coming out for this talk. I was happy to see a lot of familiar faces, actually, because a number of you actually are also very involved in the Shiley Marcos Alzheimer's Disease Research Center, and there's an excellent synergy between these two institutes, the Sam and Rose Stein Institute on Research on Aging and the Shiley Marcos Alzheimer's Disease Research Center. So it really covers the gamut of aging, from the positive and the unfortunate prevalence of Alzheimer's disease. What I want to focus on first is some successful aging, to give some good news, and I think that most of you are benefiting from having some very successful aging, and the fact that you're out here attending lectures and being socially involved and intellectually curious about the process of aging and memory. That's a very, very good sign, and it's actually good for your brain. There is evidence that that active nature of what you guys have is actually helping spare your brain neurons and keeping your brain healthy over time. What I will also then focus on are some brain changes that occur with aging and disease, both with just healthy aging but also with disease, and that's one of the topics of my interest, is being able to find the earliest signs of something going wrong. And one of the best ways to do that is actually to look right in at the brain itself and actually look for some of the changes that occur structurally. But I'll also show you some of the other advanced imaging techniques that we use in our research to try to come up with biomarkers or measures that are inside the body of something going wrong, okay? So that we can intervene as early as possible. So structural MRI, just looking at the structure of the brain, using some of the exquisite imaging techniques that MRI provides, has been very, very powerful, and I think that's very useful technique because it has a near-term application in clinical practice. Some of the other approaches will probably be coming down the line maybe in the next 5-10 years. It's going to take a while to be able to get this into clinical practice because there's a lot of barriers to trying to make the research techniques very high throughput, such as it needs to be in clinical practice. Then I'll also talk to you about measuring brain activity using magnetic resonance imaging and positron emission tomography, and then also a new approach that's actually allowing us to look at the bad protein of Alzheimer's disease called amyloid using positron emission tomography. And then I'll hopefully just have time to conclude at the end. But I've got a lot of slides to get through, so I'm going to move a little bit quickly. Well, this is one of the the positives and the negatives of what we have to deal with in aging research. This left image is the traditional population pyramid that was probably in place in the early 1900s, and that's when, before antibiotics and before we were able to cure or at least sustain people living through their heart disease and other issues that occur. So in those days, people would die off before they became in the ages of 85 or more, where we really have a high prevalence of Alzheimer's disease. Now, it turns out that if you live to age 85, there's a lot of evidence to suggest that the amount of Alzheimer's disease in that population is essentially almost 50%. So if you live to age 85, it's a coin flip of whether you will have Alzheimer's disease or not, which is a shocking statistic. And it means that this is a very critical disease to be focused on at this time, especially as we have a large bolus of individuals getting ready to head into those ages. Turns out that after curing a lot of these diseases of younger people, we now have a large group of people getting ready to enter into these golden years of their life, and the problem is that we have very few treatments that can really actually halt the decline of Alzheimer's disease. There are some positive things that are coming down the line, and I can talk to you about that if I have some time. But first, let's focus on what is the good news. The good news is that we are having more and more people being able to live even to their hundreds, and a lot of them very, very successfully aging into their 100s. In 1900, this was extremely rare to live into your 100 years old. In 1982, in the entire world, there was 32,000. In 1998, 61,000, and it's estimated in 2050 that we'll have as many as 600,000 centenarians, people living above the age of 100. How about getting to 110? So that's called a supercentenarian, and that is very, very rarely achieved. At that age, and starting at about 113 years old, the number of individuals who have been recorded to have achieved that age is only less than 120 people. And as you get to 114, 115, 116, there's a very steep drop-off. There does seem to be a ceiling and a difficult border to get past in terms of living past the 116 years of age. However, if you look out here, we have almost all of this accounted for by a single person, Jeanne Calment, who lived in France and has a very spry personality all the way until the end. Actually, she was interviewed multiple times by the news media talking about, well, what in the world? How are you doing this? How are you living to be 121, 122? And she'd say, I think God just forgot me. So, and she would say, and showing the sharpness of her mind, she'd say, well, I have one wrinkle in my body, and I'm sitting on it. So she was a very successful ager, and so we all kind of would like to strive to have a brain that would sustain ourselves until that age. There have been a number of people that have been extremely successful into their twilight years. Picasso, productive past age 90, Titian, Michelangelo, Verdi, Galileo. A lot of people have actually been able to show very, very successful cognitive aging even in the 90s. And now let's even talk about physical success into the 90s. Age 90, the world record for the 100-meter dash is 20 seconds. That's not too bad. That's pretty fast. And triple jump, you imagine a 90-year-old doing the triple jump, and they're doing pretty well at it, and the discus and the javelin. Now, of course, there is some physical decline that makes the world record a little bit less than what it is in the rest of the population. However, it's still pretty impressive of what can be done in those ages. What I'm showing here is the structural changes that occur in the brain as a person ages. Now, just with normal aging, there is shrinkage that occurs in the brain, okay? And there's a rate that we know that is very common as a person ages into their 80s or so, right? Now, but there's also a degree of atrophy that is markedly abnormal, and that is with neurodegenerative illness such as Alzheimer's disease. So let me show you a little bit about that. First, let's talk about causes of memory impairment in aging. Not all of it is neurodegenerative illness. So a lot of what can happen with aging is slowing down of retrieval and inability to come up with those names that you're searching for. And that's, a lot of that is actually normal with aging. Okay? But of course, there's a very high prevalence of Alzheimer's disease, and so the difficult thing for us is when we get an elderly person coming in saying, hey, my memory is slipping, and we do all the tests and we say, well, compared to other people your age, you look pretty good. You're basically at the same level as other people your age. And the person says, no, 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 you didn't see me when I was 50 years old. My brain was this sharp. And so then we have to take that as a physician and say, well, they know better than I do what they were like when they were 50. So it becomes very, very difficult to know whether this is abnormal change or if it's just normal aging change. And so what I'm going to present to you are some biomarkers that might help us make that distinction. Medications can also impair memory. Alcohol, certainly. Depression can look so much like Alzheimer's disease that in some cases it's called pseudo-dementia. It can really throw off a neurologist if a person is depressed and has marked memory problems. So this is something that definitely needs to be addressed in the clinical picture. Anxiety, well, that's a vicious cycle. We have a person who's getting in their 70s or 80s whose mother had Alzheimer's disease, and now all of a sudden they had an episode where they lost their keys, or they parked their car in the parking lot and they can't find it. Now all of a sudden, very, very anxious, very attuned to every slip in memory, and that can actually be harmful to memory itself. And then you have more slips, and then you get more worried. So this is one of the things I think that we can intervene even before the time of Alzheimer's medications to be able to help the patient, to relieve the anxiety in some ways if we have marked evidence that the person is normal or undergoing normal memory change. It's normal to lose your keys. It's normal to sometimes forget where you parked your car if you weren't paying attention when you parked your car. Head trauma certainly can be impairing memory. So what I'm going to talk about is I'm going to focus a lot on the medial temporal lobe. This is a structure that Dr. Larry Squire, who's here in the audience, has really pioneered the work in understanding what the function of the hippocampus has been. So we now understand that the hippocampus is absolutely critical for forming new memories. In fact, if you were to lose the hippocampus, you would be unable to form a memory for facts and events. And I'll give you a quick example of that in the next slide. But there is damage to the hippocampus, certainly in Alzheimer's disease. This is one of the first structures that is damaged by Alzheimer's disease. There's damage to the hippocampus in traumatic brain injury, in hypoxia, in epilepsy, and there's good evidence that there's damage due to post-traumatic stress disorder and high levels of glucocorticoids. So this is the hippocampus. This is the structure that I'll focus quite a bit on, so I wanted to show you a dissection that I did back at Stanford, kind of showing that I was obsessed with this structure for quite a long time, because I think it's such an amazing, beautiful structure in the brain. Such a small region in the brain, and yet it's responsible for your ability to lay down new memories. And it's such a critical ability to your function in life. So this is the hippocampus, just 5-6 centimeters in length, and then here's a large white matter bundle, a connection of wires basically from the hippocampus running into a structure called the mammillary bodies. And the circuitry is very interesting, but I don't have time to get into it. Why is it called the hippocampus? It's called the hippocampus because it's supposed to look a little bit like a seahorse. So this seahorse, which is Latin hippocampus erectus, and you might see, well, does this look kind of like a hippocampus? Well, in case you can't see it, I've superimposed them there for you. So I'd say, yeah, it could look a bit like a hippocampus and or like a seahorse. And so that will hopefully help you remember the hippocampus and what why it's named this way. So this is some more detailed images to look at the structure of the hippocampus and the cells within the hippocampus. This cytoarchitecture, or the connection between cells in the hippocampus, is extremely interesting. There's a huge number of neuroscientists that are focusing their entire basis of research on these very interesting connections between cells in the hippocampus and why and how that allows us to form new memories. Again, I don't have time to get into it, but I did want to show you at least this structure of the hippocampus and this little fluid-filled space just to the lateral aspect of the hippocampus, which if we see this structure shrinking, what's going to happen to this structure? It's going to expand. Okay? So that's another aspect of the biomarker that we can use to say that this hippocampus, if it's a certain size, and we can tell whether that thing was small all throughout life, or does it seem like it's atrophied or shrunken later in life. Here's the example that I was going to tell you that helped us learn quite a bit about the function of the hippocampus. This was from a very wonderful person that dedicated his life to helping us understand more about the function of the hippocampus. He had a very unfortunate event when he was in his 20s, and that was he had, even in his teen years, was having multiple seizures a day, as many as a dozen seizures a day. And he was saying, none of these medications are helping me. None of the medications of the 1950s were helping him stop those seizures. So he went to Hartford Hospital in 1953 to get an evaluation to say, I can't live like this. I can't hold down a job. You know, I have to have these seizures stop. And they said, well, we think the seizures are coming from your hippocampus, and there is an experimental procedure that we could do surgically to remove both hippocampi, and that should help stop the seizures. So he said, I'll do anything. I would like to have that procedure done. So they did. They went in and removed both hippocampi. And they were correct that the seizures were coming from a hippocampus, and now we still do a procedure to remove a bad hippocampus if it's causing seizures. We do not remove both hippocampi, and we learned that from this patient, Henry Malayason, who only died a couple years ago. But from that time, 1953, until just a couple years ago, he really was allowed himself to be studied by many, many neuroscientists to understand why his memory was so severely impaired after the surgery. From the moment he woke up from the surgery, he's saying, what have you done with my memory? I cannot remember anything that is happening. He would describe his life as if, right now I'm wondering, have I done or said anything amiss? At this moment, everything looks clear to me, but what happened just before? That's what worries me. It's like waking from a dream. I just don't remember what happened the moment before. So even things as salient as his own mother dying, he would need to be reminded of that. Even things as salient as man landing on the moon, shocked and amazed as it's happening, but as soon as he's distracted, and then you bring him back to that and tell him that it happened, he would be just as shocked as the first time. That's how critical the hippocampus is in making new memories. And it is the first area damaged in Alzheimer's disease, and that's why the first clinical signs of Alzheimer's disease is memory loss. So now I'm going to go on to just showing you about structural change that happens in neurodegenerative illness. So what I'm showing you here is a brain with very markedly shrunken frontal lobes. And this is a syndrome called Pick's disease or frontotemporal dementia, where there's a marked loss of tissue in the frontal lobes. These folds in the back of the brain seem relatively well spared, but the frontal lobes are markedly shrunken. You may or may not be able to see that, but trust me that there's marked shrinkage in that area. Okay? So here's a brain from UCSD that shows the same syndrome with markedly shrunken frontal lobe regions and spared parietal or back of the brain type regions. So this is, to us, a very powerful biomarker to being able to say, well, are we going to be able to detect frontal lobe dementia by measuring the structural change of the frontal lobe, because we know that that's the area that degenerates. And that's a different area that degenerates from what happens in Alzheimer's disease. So right there you kind of have a very a powerful approach to being able to distinguish these two dementias. So brain imaging is one way to look right into the brain and see what's going on. And the first sets of brain imaging that was done, well, at least the ability to be able to look at the structure of the brain, is computed tomography, or CT. CTs have become much more high resolution than what this is, but indeed it's not anywhere near what we can get with MRI. So take a look at this MRI image and take a look at the different sequences that we can do, and these days it's almost as if you're cutting open the brain and looking right at it. So the power that's that's afforded by this to clinicians is the fact that we can now look at the structure of interest and say what might be going wrong. But the ability to say how much shrinkage has occurred is a little bit more complicated than just looking for tumors or strokes or bleeds. So I'm going to talk to you about that a little bit here. So here's an example of structural change where this side of the brain is markedly shrunken relative to this other side of the brain. Now, a radiologist, even if they were just looking at the brain for tumors, strokes, or bleeds, they would notice this. And they would say, oh my gosh, this person's, this side of the brain is markedly shrunken relative to this other side. But at what point would they have been able to determine that? I mean, right now this is so severe that the patient's having marked problems. What about 5 years before that? Would they have been able to pick that up? A lot of times not. And so what we would like to argue is to use more quantitative techniques to be able to squeeze as much information out of this exquisite image of the brain as possible. So what is quantitative imaging? Really, quantitative imaging is taking an image and taking values out of that image and feeding it back to the referring physician. We do this all the time in cardiology, where we ask to get an echocardiogram, right? So they use an ultrasound to look at how the heart is beating, and when they get that information, they tell the referring physician this patient's ejection fraction is 55% or 43%, and it tells us something. They don't say, well, the heart is functioning pretty well, and they actually give us information that we can follow across time and manage our treatment based on that. So echocardiogram is clearly something that's already been able to use quantitative imaging in a very useful fashion. Well, we would argue that neuroimaging should be able to do the same thing. So in positron emission tomography, we can look at how the brain functions, and we'd like to be able to quantify how much change occurs in a patient with neurodegenerative illness. Similarly, with magnetic resonance imaging, where we're looking at a structure of the brain, we'd like to be able to say, how shrunken down is this? I know you're saying it's kind of shrunken down, but really how shrunken down is it? And how shrunken down is it relative to other people this person's age? Is this abnormal for an 80-year-old? Is it completely within the range of normal for an 80-year-old? So that's my line of research, at least one aspect of my line of research. We've known for a very long time that one can take these images, and Dr. Squire again was quite a pioneer in this work as well, looking at the structural volume of the hippocampus from MRI images. And we know that this is a very powerful biomarker of Alzheimer's disease, an ability to tell at a very early stage whether a person has neurodegenerative illness by measurements of this hippocampus, the memory structure. So as you can see in this patient on the right, this is an Alzheimer's patient with very shrunken down hippocampus and expanded black areas of the brain. That's the fluid-filled space called the temporal horn. This has been known for a long time, in the 90s. However, in clinical practice, it'd be very difficult to have a person sitting in the hospital drawing the hippocampus on every slice of every brain that comes through the radiology practice. So until now, where we've had much greater advances in computational approaches, this has not been able to be brought to patients. And so what I wanted to describe to you are some fully automated approaches to getting this same information. So this is a fully automated segmentation of the brain structure, and the hippocampus here in yellow, and you can see that the labeling of this hippocampus would result in a smaller volume than the labeling here. So let me show you that in more examples. So we've learned a lot about this from a very large study going on across the nation called the Alzheimer's Disease Neuroimaging Initiative. This is a $70 million trial funded partially by the government, but a lot of it came from industry, pharma. Why? Because they want better ways to know whether their drug is having an effect. So instead of just testing a person's cognition, they want to look right into the brain and say, is my medication that I'm testing, is it halting the decline of this structural atrophy? So in this study, there are 200 elderly controls scanned almost every 6 months. 400 patients have the very earliest signs of memory impairment. They don't have dementia, they don't have Alzheimer's disease, or at least what is called probable Alzheimer's disease, where the person can't do their functions of daily living. These are the patients that just come in saying, "Doc, my memory is slipping," and the spouse says, indeed, his memory is completely slipping. So that's called mild cognitive impairment, and you do some testing and say, yes, there's some impairment on memory here, and therefore you make the diagnosis of MCI, or mild cognitive impairment. That's a very interesting group to study, because that's where we want to intervene. We don't want to wait until a person is demented and cannot do their activities of daily living before we institute treatment. But the problem is, even some of you might have mentioned when I said, well, your spouse says you're having memory problems. Well, that doesn't necessarily mean that you're heading towards Alzheimer's disease. It's a very difficult time. It's difficult to distinguish those folks who have mild cognitive impairment who are going on to Alzheimer's disease, and those who have mild cognitive impairment who are in the earliest stages of, or who are going to stay stable, versus those who are going to decline into Alzheimer's disease. So that's where we want to focus on, these patients with mild cognitive impairment. And the beauty of this study is that instead of just using a single site and a single type of scanner, a lot of effort went into trying to make sure that the results of this would be applicable across the nation. Meaning, I don't want to only have results that are able to be translated to hospitals with General Electric scanners. I want to be able to say, no matter what type of scanner you buy, we can do the same, we can get these same results. So they made a lot of effort to make sure that the results would be equal, whether it was a GE scanner, a Philips scanner, or a Siemens scanner. And it turns out that the imaging approach that one uses to study these patients is available on every clinical scanner. So the beauty of this is that it can be immediately applied to clinical practice, a lot of these approaches. And then I want to show you something about image deformations. This is actually my head. So it was a scan done at a 3 Tesla scanner, and it just is shown to represent how the scanner changes the shape of the brain, not physically, but the images are not really accurately representing the shape of the brain. So if I wanted to do very, very accurate volume measurements of the brain, I wouldn't get accuracy out of this left image. I would have to correct for this alien type shaping of the head that has occurred here. So this is something that is allowed in ADNI and has really helped show the importance of doing this correction. So let's look at quick segmentation of the brain using fully automated algorithms to get every structure of the brain labeled and therefore measured. So this is a movie that shows a slice through of a high resolution MRI showing that you can actually get volumes of every single structure in about 8 minutes. So that's a real beauty of this, and I think that already we've gotten a number of physicians referring to our practice at UCSD to get quantification of brain structures here. So here's a healthy individual's brain who was segmented, and this cut is called a coronal cut. It's as if you've cut the face off of the image and you're looking into the brain. You know, the front is cut off from the back and you're looking at the brain in that fashion. That allows you to get a good look at the hippocampus. And now compare that to this brain, which even just obviously looking at them side by side is markedly different. And this brain is an Alzheimer's patient's brain. So you can see that the hippocampus is one of the structures that's most markedly shrunken down. Okay? So the idea is to be able to take a person who comes to the clinic. So we're not sure if they're normal aging anymore. They come to the clinic, so there's something wrong. They come to us and say, "Doctor, my memory is slipping." And then we do some tests and we find indeed it is slipping. And we would make the diagnosis of mild cognitive impairment. At that point, we don't know whether they're really going to go on to Alzheimer's disease or remain stable over time or potentially have a different type of neurodegenerative illness that leads to dementia. What we're arguing is that one should look in the brain at this stage and get an imaging phenotype, or a look at what the brain looks like. Does it look like a normal controls brain, or does it look like an Alzheimer's brain? and let's quantify the structures to say which it looks like. And it turns out that if there's atrophy or shrinkage at that stage, then it's very likely that this patient is going on to Alzheimer's disease if that shrinkage is in the hippocampus. And we have a lot of longitudinal data to support that. The good news is that if a patient comes to us with memory impairment, even though they have memory impairment, and we look in the brain and we find no atrophy, it's very unlikely that their memory impairment is caused by neurodegenerative illness. And so that patient is likely to have no change over time. All right? And then finally, we're trying to look at patterns of structural change that might allow us to determine whether they're going on, if they do have atrophy but it's not looking like an Alzheimer's type atrophy, maybe they would go on to a different type of dementia that might require different treatments in the future. All right? So we're trying to push the diagnosis as early as possible so that we can spare function as long as possible. So this was picked up by Sanjay Gupta, and it was very, this idea was very appealing to him. He spent a good 8 minutes talking about this idea that you can look in the brain and see whether a patient's brain has the picture that looks like Alzheimer's disease, or does that patient's brain just not look like Alzheimer's disease. Look at the difference in clinical course in those different individuals. They look exactly the same when you're first evaluating them. But this in black are patients whose brain looked like a normal brain. And you can see they have no decline on this test of cognitive function over the next year. And those patients who have atrophy that looks like Alzheimer's disease, they shrink, they not shrink, they have loss of cognitive function over the next year that's just like an Alzheimer's patient. So we would love to be able to reassure these individuals and to take these individuals, give them education and get them into a clinical trial and maybe change our risk-benefit ratio of the medications and make sure that we know that this individual probably warrants a more aggressive treatment option. Okay? All right. And in fact, the National Institute of Aging is looking to revise the diagnostic criteria for Alzheimer's disease. It was developed more, 25 years ago or more. So this previous approach to diagnosing Alzheimer's disease, where you would just look at a person's function and say, well, they're demented, they're not able to do their activities of daily living, and they have a memory problem, that means they have Alzheimer's disease. Now we have much better approaches to look inside the brain, and the National Institute of Aging and the Alzheimer's Association said, well, we better make use of those things. Let's now change the diagnosis to where it requires the presence of a biomarker, such as MR imaging, PET imaging, or a lumbar puncture to get some of these measures of the bad protein in the brain. Okay, so I'll zip along. Bridging to clinical practice, I've kind of touched on that quite a bit. The idea is that if this is fully automated, what you can do is scan hundreds of individuals across the age range, hundreds of individuals that are normal and documented to be normal, and then measure the structures that you're interested in, and then find out how much variability is there for an 80-year-old, how much variability is there for a 72-year-old, how much should the hippocampus be shrunken down in a 50-year-old. So what you can do is turn it into something like a blood test, essentially, where you just compare the measurements that you get to your normative database and say, are they within the range of normal or are they out of the range of normal? So we've done that for the hippocampus and that fluid-filled structure called the temporal horn, and for the fluid-filled structure of the rest of the brain called the lateral ventricles. And what we can now do is present the volumes that we achieve as a percentile of the normative range. And here's what the report looks like. So what we do is, so this is a 72-year-old female who came in and certainly had memory impairment and got her brain quantified. And it turns out that this white area is the normative range for a 72-year-old person. The hippocampus should fall, the volume should fall within that range when corrected for the intracranial volume, for how big the head size is. And it turns out that hers, just looking at it, I can see that it's markedly shrunken, but quantifying it, you can see it's well below 2 standard deviations from the mean. And concomitantly, the fluid-filled structure next to the hippocampus is markedly expanded. So that allows us to be able to say that this shrinkage is likely due to some change that happened during the patient's life. What I wanted to show you are a couple of examples where you look at a brain like this, and remember, already you've learned enough about the hippocampus that there should be a nice yellow structure here. Well, there isn't in this case. This person was 89 years old. So the radiologist looks at it and says, well, there's very, very shrunken hippocampus, but he doesn't know whether that's normal for age or not. So his report just talks about the fact that there is a lot of atrophy. I'm not sure if that's abnormal for the person's age. Ventricles are normal. There's no blood, there's no stroke, and there's no tumor. And everything else looks pretty fine. She's had cataract surgery. And essentially, you go back to this patient who has marked memory loss, and you say, well, the radiology report says your brain is normal. But in fact, it is not normal. If you do the quantification, you find that even for an 89-year-old patient, this person's hippocampus is markedly small, and this person's temporal horn is markedly out of the range of normal. So you would go back to the patient and say, unfortunately, it looks like there is more shrinkage than expected for your age, and I think that it might be neurodegenerative illness, and we should talk more about potential for clinical trials and more aggressive treatments that might be able to halt the neurodegeneration. And also just planning. Things like, we should have somebody evaluate your driving, because it might slip, and we need to make sure that you're safe. All right? So another case, just another example. Again, you know enough about the hippocampus, markedly small hippocampus. And the report comes back, brain volume is normal for age. Okay? And to their benefit, the radiologist's benefit, I mean, really, it's hard to keep in your mind a database of how large the hippocampus should be across the age range. And again, this was an elderly person. They were in the mid-80s, but clearly well out of the range of normal, and including the temporal horn, very much out of the range of normal. All right. So one very exciting thing for us also is that because of the Alzheimer's Disease Neuroimaging Initiative, we not only have MRI on these patients, but we also have lumbar punctures on a lot of these patients. So it's very, very, we are so indebted to the patients that have, or patients and healthy controls who have come in and say, I want to help the fight against Alzheimer's disease. They come to our study center and they say, I'm so dedicated to this that I'm willing to get a lumbar puncture, a spinal tap, to help you in this fight against Alzheimer's disease. So these individuals that helped us give the fluids that we could study allow us to know that combining biomarkers is even more powerful. So I think for the first time really in history, we can take a patient who comes in with a clear memory impairment and has a lumbar puncture that says they have no amyloid in their brain. They have no bad protein of Alzheimer's disease in the brain, and they don't have atrophy based on the MRI. You combine those, and essentially for the first time you can tell this patient who has memory complaints that you have no greater likelihood of going on to Alzheimer's disease than a normal elderly person your age who does not have memory complaint. For me as a neurologist, that's extremely exciting because we've never been able to give that kind of reassurance to a patient who comes to us with a clear memory complaint. So now we have biomarkers that may be able to tell us that your conversion to Alzheimer's disease is no higher than what we would see in a normal elderly person. On the other side, if you're positive for both biomarkers, it is very bad news. It means that you have a rate of conversion to Alzheimer's disease in the next 3 years that is above 80%. So, but the positive on that is that we now know it, and we can start planning for that and educating and intervening. So a lot of people say, well, there's no treatment for Alzheimer's disease. And I, as a neurologist, kind of get offended by that. And I say, you're saying that the only treatment we do as a doctor is write prescriptions? No, we treat, we manage, we educate, and we help the family get through this difficult syndrome. So very briefly, I want to talk to you about the power of looking not at a brain compared to a normative database, but a brain compared to itself a year ago. A brain compared to itself 2 years ago. This is an extremely powerful approach because now you can say, how much did this brain change in the interim? And we have nice computational approaches to pick up that change that occurs across time. So let me show you the change that happens even in a time as short as 6 months in a patient who has only 1% per year, 1% per 6 months atrophy, so 2% per year. Look at the change in the brain that happens in just 6 months. So that's a sort of a scary prospect, but you look at this side by side and you say, well, it doesn't look that extensive. But if you really put them right on top of each other and perfectly align them, you can see that there is structural change happening even in its time as short as 6 months. So what we've developed is a way to do computer-assisted clinical detection or detection of interval change. The details, I won't go through all of this, but essentially what we're doing is taking the two brains, registering them together without doing any shifting around of structure, and because there's such complexity to the brain, we can get those brains to snap together almost perfectly if there's been no structural change. If there's been structural change in the interim, there's no way you'll get those two brains to line up perfectly using just these rigid body alignment techniques. You'll have to start shifting internal structure. And then we can quantify how much shifting of that internal structure we had to do to get the first time point to fit into the second time point, and then say, well, how much did each of these structures change? And so it's a very powerful approach, and I'll show you the images that come out. Just from viewing these, you can look at the expansion of the ventricles in red and shrinkage of the cortical margins in blue that happen in a time as short as 6 months and over a year. And we know the pathology of Alzheimer's disease starts in the medial temporal lobe and starts spreading out to the lateral temporal lobe. Well, indeed, in these patients, we're seeing that the marked change is where the pathology is now. So we want to be able to study this a little bit more to really figure that out, but it seems to me that this is an in vivo look at where the dynamic changes are going on in the brain. So the pharmaceutical companies are extremely interested in this because they want to say, can my medication halt that? And the FDA wants to know, if you're going to say that this drug actually stops neurodegeneration, you better have a biomarker, because just testing cognitive function, you can get very mixed up between a symptomatic benefit, like a cold medicine, and the rate of decline. Because Alzheimer's is such a slow process, a drug company would have to have 5 years, 10 years to be able to detect the change that they want. So they want to be able to know in 6 months, 12 months, maybe at most 18 months. And the only way really to do that with power is by looking in the brain itself and looking at the physical change that occurs. So these are brains compared not to a normative database, not to normals, but these are patients compared to themselves 1 year earlier. So you can see that the structural change is exactly the areas that we've seen in the past with where the Alzheimer's protein is. On the bottom are normal controls over that same period of time. So the change is marked in these patients compared to themselves. We're very interested in looking at this to distinguish between different neurodegenerative illnesses. I'll flash through this. There are other syndromes that shrink the brain in different ways. This is an individual with a syndrome called posterior cortical atrophy. Very interesting syndrome. The patients present to an eye doctor because they say, I can't see, and yet they're looking right at you and they're making eye contact, and they really can't see because the cortex that is responsible for interpreting visual input is degenerating. And so we can see that that is taking place in looking at this patient across 18 months and seeing the change that has happened. Here are patients with dementia with Lewy bodies, which is an interest of ours, a very difficult disease to distinguish from Alzheimer's disease, so we'd like to look at this biomarker and its ability to distinguish those neurodegenerative illnesses. So we got a little bit, not too much time, but this is really looking at the Alzheimer's Disease Neuroimaging Initiative database. In green here are all the normal controls and their rate of change on the y-axis here. So most of them are fallen right here, not very much change over a period of 6 months. And in blue are the Alzheimer's patients. So they're changing quite a bit in 6 months. In red are patients, are individuals that came into the study as normal controls, but their brain is changing like an Alzheimer's patient. So what I wanted to do is to try to find out whether I could distinguish those individuals from the normal controls and predict later decline even before they had a memory complaint. So first let's just look at the normal controls and the overlay of change across the brain, and you can see that these individuals have essentially no change. They look quite normal. This individual from UCSD was recruited as a normal control. We now know she converted to Alzheimer's disease over a period of about 3 years. She had mild cognitive impairment at 12 months. But this was when she was still a normal control, and we saw that there was marked change going on in her brain, and you could see the hippocampus shrinking quite rapidly over a very short time. So multiple time points, which would be very difficult to pick up visually, because these are the different time points, baseline, 6 months, and 24 months. Just looking at those images, it's very difficult to visually distinguish the change that has happened. But using the computational approaches, we can highlight the change very well. This is predictive of later clinical decline. And Liz Murphy from the lab, one of the medical scientist training program students in the lab, did a very nice study that's been published in Neuroimage showing that you can predict structural change, you can predict later decline in memory based on 6-month interval scanning to see the structural change that happens. Now I just wanted to show you some of the recruited patients for the Alzheimer's Disease Neuroimaging Initiative. This was done in an approach just to kind of see whether we could detect on an individual subject basis who had Alzheimer's disease and who did not. So here's a patient, and I think you can already just look at it and say, there's a lot of change here. And if we were to look at the quantification reports, very abnormal hippocampus, changing and expanding temporal horn, and structural change across the brain. So what do you think it is? It's unfortunately Alzheimer's disease. Here's a patient. This is the one that I just showed you. Does have structural change over 6 months and definitely over 24 months. Changed a lot in the quantification. And here's the brain change. And this is the normal control who later converted to Alzheimer's disease. This patient or individual looks pretty good, just visually looking at it. No change across the time and no change in the brain, and that's a normal control. Here's an individual that looks pretty shrunken down, but there's no change across time and was actually quite stable over the time and had no change across 24 months, and it turned out that person was normal. So that was a good demonstration of the use of both longitudinal and baseline imaging. And then here's another Alzheimer's patient, again just showing the change across the brain. So we think this is very promising as an approach to change the diagnosis of Alzheimer's disease in using MRI as a biomarker. I just wanted to briefly run through some of the exciting new approaches of imaging. This is called diffusion tensor imaging. It allows us to look at the way that water moves in the brain to get a look at the connections between structures in the brain. These are the images that can come out of it using a fully automated approach to be able to pick out the different connections between major structures of the brain. We are very interested in looking at brain activity using functional MRI, looking at the medial temporal lobe activity in individuals. But task-based MRI is very difficult in a patient with Alzheimer's disease. So what we'd also like to look at are things that where a person just rests in the scanner and how the brain modulates throughout that time. It turns out that different regions of the brain tend to activate together, and it may be a very powerful biomarker for Alzheimer's disease, and we're very interested in exploring that approach. PET scanning, I've already talked to you a little bit about that. That's looking at where the brain's active or not. And here are pictures of a fused MRI with PET scanning, where we can get quantification of the measures of metabolism in different regions. And then finally, PET scan for detecting amyloid, the bad protein of Alzheimer's disease. This is going to be coming out very, very soon, and it looks like it'll probably be FDA approved in the next year. But what they're wanting is a very good way for the radiologist to be able to pick up whether a person is positive or not. Because you don't want to be making a mistake saying, oh, I think this person has amyloid in the brain. Essentially, you're saying the person has Alzheimer's disease and it's coming down the line. So the FDA said, no, I want a very objective approach to be able to say whether a person has amyloid in the brain or not. And so we think that making use of quantification of structural, or of using a structural scan and the amyloid scan will be one of the very powerful approaches to doing that. And then, as you guys may have known, if you've been in a scanner ever, we ask you to stay as still as possible, right? Because that's one of the things. And in a patient who has dementia, it's very difficult to say, please stay still. So that's been a challenge, but I think we're about ready to overcome that by using a thing called prospective motion correction. So I'm going to show you an image. On the left side is the corrected image, and on the right side is how this patient is moving in the scanner. So moving a bunch, but our image stays rock solid because we're able to account for that change with very quick 10 millisecond navigators to say his brain is now here, let's change the parameters. So now it gives you a very beautiful image across time to be able to get locked, beautiful images even if a person's sitting in there moving around in the scanner. Finally, I've mentioned a little bit about maintaining healthy brain function. I wanted to end on a positive note, essentially, and that is that you guys are doing exactly the right thing, and I think that it's very inspiring to see so many people come out despite the weather, and really you're doing all of these things. Cognitive activity, you did at least rush through the rain. I'm sure you got a little physical activity. You're certainly socially connected. Well, we got cookies out there, so maybe we'll work on that. But definitely keeping good vascular health is going to be one of the things that will help you maintain that good brain function into the end. So the summary is really brief. It basically says that this imaging is a very promising new biomarker for clinical practice and for detecting effects of medications in the future. So I wanted to thank a lot of my collaborators, Anders Dale's lab, and a lot of folks from the multimodal imaging laboratory, as well as individuals from my laboratory, the human memory lab at UCSD. So thank you very much, and I'll take any questions. Okay, so the question was, does successful aging postpone the symptoms of Alzheimer's disease? And I would say yes, there's evidence for that. So two things. One, some of successful aging is just luck, your genes. And but a lot of it is also what you do. So your DNA helps you successfully age, but also what you do. If you've maintained the brain function throughout life and continue to maintain brain function, you can still keep doing what you're doing despite damage that's going on from that bad protein that's accumulating. And there is evidence that actually the activity itself keeps the bad protein from accumulating, but that's still pretty preliminary evidence, and we're trying to study that. So the question is about how does one evaluate a person who's had a learning disability from childhood or a static cognitive deficit. These patients will come to your clinic and you'll test them and say, oh my gosh, everything's down way below where it should be. Is this something new, or is this something that was there from childbirth, or since they were a child? And that, I think, is where you need to have a trajectory. And you need to be able to follow that person. You have to have some baseline to be able to say, this is where they were before, low, and this is where they are now, lower, or same amount of low. That's really the only way you can do that. The question is about saying that there is a very powerful biomarker in MRI. However, there are known contraindications to MRI. So what about that? And I will say that we're hopeful that some of these imaging techniques, including PET scanning and quantification of subregional metabolism in the brain using a combination of PET scanning and CT, might eventually be able to account for that. Right now, it's a real disadvantage to be not able to get an MRI for many things. I mean, if a person has a stroke, we want to be able to look at that change as quickly as possible, and MRI allows us to do that. So, but certain pacemakers or certain implantation or metal in the body makes it so that you can't get an MRI. So we need to just use a CT and then wait for 2 days to see how large that change is. So MRI certainly has advantages, but if you can't get it, you can't get it, and we got to work with that. Okay, so the question is, volumetric MRI seems like such a powerful tool. Why wouldn't we all go out and just get one, even if we don't have a complaint? And I'll tell you, as a neurologist, I tell my residents, don't get that MRI unless you have a reason to get it, because it is such a sensitive approach that you're going to find something in that brain, and you're going to have to deal with it. So you better have a good justification for looking that sensitively at people's brain, because there's a lot of incidental pathology, or maybe not pathology, but changes or some structural finding that may not even be meaningful. The person has no complaint, don't touch it, okay? But it is, some would argue that one would want to have a baseline against which to compare. And that'll be a question for the future, definitely, to see how well this does in patients without complaint.
Is that financial or ethical in terms of decision?
I think that one could. Okay, the question is that financial or ethical? I think these are not extremely expensive techniques compared to a lot of other tests. The MRI is $480, and the subregional quantification is an extra $138 on top of that. So it's not a huge amount, but so it's not necessarily financial. I think it's more the practice of medicine. We don't usually start intervening unless a person has something to stop them, something they're complaining about. Now, that's not necessarily the case in everything, right? Cholesterol, high cholesterol, we're giving medications. Those are pretty benign medications at this point. But if we get to these new medications, like the clinical trial that I run at UCSD, using a medication that tries to pull the bad protein out of the brain, that is a very aggressive approach. It's an infusion of an immune agent that pulls the bad protein out of the brain. That's aggressive, and it can cause bleeds and edema in the brain. So if I just took a person without memory complaint and I found some finding that I thought, I want to go ahead and use this immune agent, I could hurt that patient unnecessarily. Okay, so those are the ethical, I guess, questions that you would have. So what was brought up was that the FDA has approved an MRI-based approach to be used in patients with pacemakers. At Hopkins, we did that when we really, really needed an MRI. We would have a cardiologist standing by, and they would set the pacemaker at a certain level and say, okay, we're going in, and we're here. We're ready with the crash card if anything bad happens, because that risk-benefit ratio is got to be pretty tight. And but yes, there are some instances where a person could get an MRI even though they had a pacemaker. So I think we'll stop there. It's been a very good night. I really appreciate it. Thanks for all the lively questions.